So welcome everyone. My name is David Imbao Jacome. I am Core Group's Technical Programs Officer joining from Ecuador, and I will be the moderator of this session. So before I introduce you to this amazing set of speakers, I will just give you a big background on why we're here. The issue is that prior to the onset of the pandemic, more than 820 million people were already identified as chronically food insecure, of which 135 million people were categorized as being in crisis. The World Health Organization projected in June 2020 that these numbers could double due to the COVID-19 pandemic, putting at risk the most vulnerable. Furthermore, there's a lack of water and hygiene services in healthcare facilities, which of course it is challenging to face a pandemic without that basic resource. Hand washing is clearly the first line of defense against the COVID-19 pandemic, especially for also the survival of mother and newborns during childbirth, for example, in healthcare facilities. During this session, we'll be discussing with key academics and also advocates on how we can invest in the social and the environmental determinants of health with an equity lens to protect and improve women, children, and adolescents' health. So I have the honor to introduce you to this amazing set of speakers, which includes, in order of their presentation, it goes from, at first we'll have Purmina Menon. Purmina is the Senior Research Fellow in IFPRI's Poverty, Health and Nutrition Division and is based in the Asia office in New Delhi, India. She conducts applied nutrition research in the South Asia region with a focus on programs and policies to improve maternal and child nutrition. The second speaker will be Mary Aram Ashinyo, who is a physician specialist in public health with an emphasis on health policy and health systems management. As the Deputy Director of the Institutional Care Division of the Ghana Health Service, she is responsible for quality and safety. And last but certainly not least, we'll have Elena Dollimore, who is a Senior Manager in the Global Sustainability at Unilever, where she focuses on health and well-being. This covers Unilever's effort to improve access to safe water and sanitation and the response to the COVID-19 pandemic and other humanitarian crises. For the last year, she has been overseeing the Hygiene and Behaviour Change Coalition to help tackle COVID-19 around the world, working with the UK government, 21 NGOs and UN partners in 37 countries. So without further ado, I'd like to hand over now. Sorry, I know that they will have a poll to start the session. Apologize for that oversight from my side. Please, I don't know if the tech support can help us launching the first poll, so we can just get an idea of what people think.
1 second.
Sure. In the meantime, just for to speed up the process, I will just read the question so when it pops up, you will know what to answer. And the question is: in your country, which social need has been most exacerbated as an implication of the COVID-19 pandemic and remains unmet? Options are food insecurity, economic instability, access to education, healthy physical environment, including housing, transportation, wash, and finally, safe support systems, for example, communities, social spaces, etc. I'm going to put the question on the chat so you can take a look now until we see the question on the poll, the poll popping up. Okay, in the interest of time, we can just go back to this question later. I will now hand it over to Purmina to speak on the national challenges of integrated nutrition across different sectors during COVID-19 and how important food and nutrition assistance has been particularly for the most vulnerable and how nutrition is being integrated into multiple health sectors beyond health. Purmina, the floor is yours.
Thank you so much, David. So I'll speak to this issue primarily from research that my colleagues and I have been doing in South Asia and primarily in India, which is where we have most of the data that I'll speak about in the last year. So around this time, last year, those of us who work in nutrition, in particular, both in India and in the South Asia region, were really sort of thinking forward to say, in most of the countries in the region, they were going into or had been in a severe lockdown that began in March, even though the pandemic numbers were not yet on the rise and are certainly nowhere near where things are at this point in time, which is quite devastating. The present time, and so we tried to sort of anticipate forward a set of scenarios or pathways through which nutrition could be affected. And then at that point in time, we were really sort of predicting or trying to think forward primarily to indirect pathways. And we anticipated pathways related to loss of incomes, related to related increases in food insecurity. We anticipated pathways that related to closures of schools, leading to potentially increased, early marriages and other such things. And we don't have, and of course we anticipated pathways related to the loss and the disruptions in health and nutrition services. And what we've seen over the last year through a network of researchers who've been working together across India, and I'll drop the link to some of the work that's been done there in the chat box, is that indeed many of these pathways played out, broadly as we anticipated. There was sort of substantial increases in food insecurity. There were significant losses, of course, across education. And in fact, children and girls have been out of school. All children have been out of school for a very long time now. And then certainly on health and nutrition services. Now we've been able to analyze some of the data on disruptions to health and nutrition services in particular. And I think for this group, that's also really relevant. And one of the things that we saw is that in last year, the disruptions to health and nutrition services were related primarily to the lockdowns, especially across rural parts of South Asia. I think, once lockdowns were eased up, because the lockdowns had, in a sense, contained the infections, the restoration of services could begin to occur. And we have certainly seen that both with analyses of administrative data and through phone-based surveys that research partners have done around the country. I'm personally very, very concerned about what's happening right now, because I think what we are seeing right now as the pandemic moves into rural areas across the region is that there are going to be some very direct, not just lockdown-induced disruptions to health and nutrition services, but real hard disruptions to health and nutrition services that are because the system is responding to this incredible surge in the pandemic. I don't think we're going to know fully about the impacts of this for a long time to come. Now, the other thing, and this is related to the second question, David, that you posed, which is, what is the role that food assistance and other programs have played in sort of mitigating some of these impacts? And I think the good news is that, across, certainly across the different states in India, there were a range of different packages that were unfolded as social protection packages to reach vulnerable families. And a survey done even, as done in about October, November, certainly showed that those packages were reaching people. And so I think what we know is that those sort of social protection packages, especially food assistance, can and were delivered, really across India to multiple vulnerable families. But I think the sobering part of the analysis, and this is a survey called Hunger Watch, which was done in the most vulnerable families and communities across India, is that despite the reach of these social protection packages, families were still affected and still eating more poorly, even in November. And so I think my expectation is that this year things are going to be even more dramatically affected, unfortunately. And what we'd really like to see is that these social protection packages are thought through even more deeply and are really sort of diversified and amplified and expanded to protect food security and nutrition, because we know this is going to be a big challenge looking forward through into 2021 as well. It's not clear to me what the restoration of health and nutrition services will look like, because things right now are back, not just in the lockdown situation that we were in last year in this region, but they're also in a situation where the services and the service delivery mechanisms and the individuals in those systems are also affected deeply by the pandemic. So, I think we're going to see the impacts of this, likely in months to come, and we'll only know more about it once data systems are also restored. So let me stop there, and then we can maybe take questions and discussions that people have later on. Thanks.
Thank you so much for Mina for those remarks. I think that yes, we have seen that lockdowns have been took place all over the world, and we have also to assess what are the consequences of these lockdowns on the overall services that are provided by the governments and the ministries, because of course we need them to contain COVID-19, but they should be only addressing. They should be temporary, and they should have also the social protection measures that you are mentioning, but at the same time making sure that these protections are reaching the people that require them the most, the most vulnerables that we are here advocating for. So thank you so much. We'll go back to you after all the presentations so we can have questions and answers. So up next, the second panelist is Mary Ram Ashinjo, the Quality Lead for Institutional Care Division of the Ghana Health Services, who will be speaking on how Ghana Health Services is addressing and improving WASH within their quality efforts and key insights focus. Mary, the floor is yours.
Thank you very much, David. Greetings from Ghana. It's very sunny and hot here. So thank you for the opportunity for us to share the experience from Ghana. This is a very important discussion because for Ghana, it has been a milestone on the table for some years. But I'm happy to say that in the last 3 years, we have seen a lot of gains in terms of integrating WASH into the national quality of care programs, especially for maternal and child health, because for Ghana, maternal and child health is the pathfinder for quality of care, although we have several priority intervention areas. So when I look through all the many efforts and interventions that we have introduced in the last 3 years, I feel that there are 4 main levers or 4 main intervention areas that have helped us to integrate WASH into quality of care programs. So the first is governance efforts. The second is intersectoral collaboration. The third one is integrating into existing organizational monitoring and evaluation programs, as well as supportive supervision systems. And then the final one is community participation. So I'd like to start off with the governance efforts. Leadership is very key in many health strengthening interventions, and it is even more important for WASH in healthcare facilities because it is the very foundation for quality of care. And so what has been helpful in Ghana is the fact that we've had a very rich policy environment. We have virtually national policies and guidelines for all the domains of WASH. So we have policies for infection prevention and control, for water, sanitation, hygiene, and waste management. Before 2019, the National WASH IPC program was not driven by the quality management structures or department. And so that was one key milestone that we set for ourselves. Luckily, we were able to achieve this before the onset of the COVID pandemic. And that was really one key milestone that we attained as a country. This also provides the opportunity for us to drive WASH more integrated into quality of care at a very high national level. And that then transcends into all the levels of care, right to the community level. We have also seen a lot of national leadership support for the WASH program and its integration into quality of care in the last 3 years. So for instance, the very first National Patient Safety Day celebration, which was on the 17th of September 2019, came with a 3-day conference. And the theme for that conference was No Quality, No Coverage, WASH, IPC in healthcare facilities now. That was to say that we are all talking about universal health coverage, but really we can't talk about UHC without talking about healthcare quality. And if we want to talk about quality in UHC, then WASH and IPC in healthcare facilities become the very basic. And so that theme alone as a national conference theme demonstrated the commitment of national level leadership to ensure the integration of WASH into quality of care and beyond quality of care, quality UHC and beyond. Also for maternal and newborn care specifically, Ghana is part of the 11 countries that are participating in the World Health Organization's quality of care network for improving maternal, newborn, and child health. And so as part of the 8 standards that have been developed for this intervention, WASH and IPC have been components of this POC network, which is being implemented in many regions of Ghana. So that is in terms of governance efforts. In terms of intersectoral collaboration, although the Ghana Health Service is the largest service delivery agency of the Ministry of Health, we also realize that there are other non-service delivery agencies that also impact quality of care highly. So for instance, the National Health Insurance Authority, for instance, or regulatory authorities such as the Health Facilities Regulatory Authority. These 2 institutions are also involved in quality of care activities. And so, for instance, the National Health Insurance Authority does what we call credentialing. And then the Health Facility Regulatory Authority does accreditation. And so what we did was to approach these 2 organizations and integrate WASH and IPC indicators into their monitoring tools and into their accreditation and credentialing systems. And so these also become vehicles on which WASH and IPC is integrated into quality of care and driven and given an independent eye, because then this becomes outside of the Ghana Health Service. The third area is integrating into existing M&E and supportive supervision programs. So Ghana has a very well-patronized district health information management system, the DIMS2, and all our over 8,000 healthcare facilities report into this system. So what we have also done is to ensure that we have IPC and WASH indicators in DIMS, where on quarterly basis, healthcare facilities report into this system for us to see the status of implementation. Unfortunately, currently we have just about 52% of healthcare facilities reporting into DIMS, but it is a good start having been introduced over the last 2 years. And we see this as leveraging grounds for us to even achieve 100% coverage. We also have some homegrown bottom-up interventions that are really well sustained in the health sector. Notably is the peer-to-peer holistic assessment, which has indicators covering all programs and service delivery areas. And this is carried out on annual basis, and all 16 regions of Ghana are assessed. And so we have also incorporated WASH and IPC indicators in this holistic assessment tool, which also forms a basis of an assessment of WASH and IPC. The trick is that what is not assessed or measured, unfortunately, is not adhered to by our frontline workers and frontline managers, or is not given much attention. So once regions know that we are being assessed using these indicators, they put in a lot of resources. They budget for WASH and IPC. They make sure logistics are available. They make sure healthcare workers are trained on IPC so that they will be scored appropriately every year. And so that is also one of the levers that we have used to improve on integration of WASH in quality of care. Finally, but not the least, is participation of communities through what we call the community scorecard. So the community scorecard is a tool that measures experience of care. And there are about 8 indicators. One of them is on cleanliness of the healthcare facility. And so communities, in the absence of healthcare workers, they score the healthcare facility, whether they feel that this facility is clean. And this is being done in about 30% of our healthcare facilities. Again, it helps us to put the voice of the patient in the middle of care. But also, more importantly, communities themselves have been able to mobilize resources where there are gaps to be able to implement IPC and WASH in these healthcare facilities, including providing waste management bins and bin liners, building incinerators, placenta pits, providing hand hygiene logistics, etc., etc. Communities by themselves have been able to do this domestic mobilization. And then they also develop action plans for the healthcare facilities based on the gaps they see in the assessment. And they load this action plan into an action tracker. And so it also becomes a form of accountability tool. And it's a very beautiful program that makes the community members really feel part of service delivery. And that has really been useful. How we usually identify gaps, we do this through routine use of data. Occasionally, we'll do a survey. We also rely on JMP reports, community scorecard reports, program reports, but also quality improvement processes at healthcare facilities. And I think that is very important because we need to ensure that most of the high-level mission and strategic direction is translated into operational mechanisms to give direction to frontline workers on how to do actual implementation to adhere to standards. And so the quality improvement processes focused on WASH and IPC have been really, really good and helpful. I wouldn't say that given these gains, we are on top of our game. We have done, I would say we have done a little bit, and there remains so much to be done. We have so many challenges as well, but they also present us with opportunities for improvement. For instance, software issues, behavioral change. So sometimes the hardware logistics are available, but software is the challenge for not adhering to WASH guidelines, especially during maternal, newborn, and child health. We have seen that our cleaning staff have very high attrition rates.
Mary, I will ask you to stop now just because of time, but I think that we'll be able to get back to you later on these questions. I was just going to ask you about where we stand right now. But yeah, we'll just stop now. I will now give the floor to Elena so we can move to the next presentation, and then we will go back to you for questions. Sorry for that. So please, Elena,
thank you so very much.
Thank you so much, Mary. Very interesting presentation. Elena, please, can you speak about the work of the HBCC and demonstrate how partnerships with government and other stakeholders are leading us to results? Elena?
Yes. Thanks, David. And Mary, you said it's very sunny in Kenya. I can assure you that here in the UK, it's very rainy and very cold, a long way from Kenya. And thanks to PMNCH for bringing us all together today. It's such an important subject and great to be here. I think we've got an amazing range of speakers, just looking at some of the other sessions today as well, from all different sectors, government, civil society, academia. And you might be thinking, where does a business like Unilever fit into all of that? Well, the answer is, if you think about the 17 SDGs that we've got, those 17 bold, ambitious goals that we set out, that were a promise to the world, we would lift people out of poverty, we would tackle climate change, and we would fix inequalities. We know that there's only one way to translate that bold ambition into action, and that's by really creating a coalition that will bring together government, business, civil society, all working together towards the achievement of those goals. So it's really great to see people from across those sectors here today focused on how we can achieve SDG 3, because that is so important. I've been asked today here to speak about the role that we as a private sector company play in promoting good hygiene, and particularly our role in the COVID response over the last year with the UK government launching the Hygiene and Behaviour Change Coalition. But just to give you a bit of background on Unilever and our involvement in hygiene to date, we're one of the world's largest soap companies, and we have a very long history of promoting good hygiene. In fact, we were founded over 100 years ago in Northern England in the UK with the mission of making cleanliness commonplace. And that's very much what we seek to do today and have been doing going into the pandemic as well. I don't have to tell all of you gathered here today how important hygiene is as a determinant of our key health measures and of preventing preventable child and maternal deaths. And of course, we know that with COVID, it's become even more important. Even before COVID, we know hundreds of thousands of children are dying every year from diseases that are linked to poor water, sanitation and hygiene access. And adding COVID to that only creates more problems for the world that we knew we needed to tackle. You know, current data shows massive wash inequalities. 3 billion people lack access to a hand washing facility in their home. That is 2 in 5 people. And it became so obvious when COVID-19 began and the pandemic started to take hold in the world, how important getting hygiene access to people and promoting good hygiene to everyone everywhere was if we were to tackle COVID-19 and leave no one behind. So really that's what brought us together with the UK government to found the Hygiene and Behaviour Change Coalition. And the Hygiene and Behaviour Change Coalition is a partnership. It's a £100 million partnership that we've founded with FCDO, which was previously DFID, the Department for International Development, now the Foreign and Commonwealth Development Office. And it's a public-private partnership to tackle COVID-19. We think it's the biggest public-private partnership tackling COVID-19 around the world. And we've contributed together £100 million towards hygiene programs in 37 lower and middle income countries across Asia, Africa, the Middle East, South America, and the Pacific Islands. And these are being implemented on the ground by our partners. And I know today we've got many partners here on the call today. I can see many of them on the call from Save the Children, from UNICEF. Brilliant to have some of you here today, but really our work is achieved on the ground through our implementing partners. And we have 21 of those. We approached the challenge of COVID-19 really from 2 key angles. We wanted to tackle the supply issue. We wanted to make sure everyone had access hygiene infrastructure, building hand washing stations, giving people access to soap. We did a €100 million product donation of soap as well. Rainwater harvesting to make sure people had access to water if that was an issue in some areas. But also, it's not enough to just tackle the supply side. You also have to tackle the demand. And we had to implement behaviour change programs to make people aware of the risks with COVID-19, encourage them to practice good hygiene, and also show them the benefits of doing that and convert that knowledge that they have into actions and into good behaviour practice. Our public-private partnership model allowed us to really work together rapidly and at scale. The results are very impressive to date. We've reached over 1 billion people, and that number continues to go up. We also have great results in terms of reaching groups that we know we have to target specifically because there's a risk they could be left behind otherwise. And I'll talk more about that in a minute. But really what the HBCC is, and we did have a slide, but I think the sharing permissions are disabled for my colleague Anjali, so we can't put that up. But what we wanted to do with the HBCC was to bring our expertise to the table as a private sector company with a large history of expertise in hygiene behaviour change, and brands that have for many, many years been working on hygiene behaviour change. Our biggest soap brand, Lifebuoy, has been working in schools, in communities for decades, really, encouraging children to wash their hands with soap more and communities to do that too. We had those programs, we gave those programs to the humanitarian community to scale up in response to COVID. We also led the creation of a global set of assets that partners in the HBCC could use to promote awareness of COVID-19 and what behaviours you need to practice to prevent COVID-19, the hand, face, space, surface campaign. And all that is based around the idea of a password, hands, face, space, surface, to get our lives back from COVID-19. That's been translated around the world, over 20 languages. And NGOs have told us they found that very useful, and the expertise that we were able to provide as a large marketing company in creating those assets was very helpful to them. What FCDO brings to the table as well is their large expertise in delivering programs like this at scale, and a £50 million contribution as well to support programs on the ground. We also have the support of the London School of Hygiene and Tropical Medicine, LSHTM, who are our technical partner to the coalition, and they help us ensure the maximum quality of programs on the ground. And like I said, we couldn't do any of this without our partners on the ground, who really take everything to the last mile and make sure on the ground we're leaving no one behind. And something that we set out to do from the start with HBCC, front of our mind, was those places, those communities, those groups in the world that don't have access to wash facilities. If you're a refugee in the world's largest refugee camp in Cox's Bazar, Bangladesh, you know, social distancing is impossible. There is nowhere to wash your hands often. How are you supposed to protect yourself from COVID-19? So we wanted to fix that first as well. And we did take a particularly targeted approach with groups that we knew were vulnerable to COVID-19, refugees, people with disabilities, and we also took some specifically gendered approaches to target women and girls as well, and make sure they weren't left behind from these efforts. Just to give you a few examples from our on-ground programs, ActionAid took a gendered approach in Kenya. They led their work against COVID-19 through a gendered lens by empowering women, focusing on women and girls in the community as agents who could spread COVID-19 awareness messages. And they also continued their important work on preventing domestic violence in the community, which we know has spiked during COVID-19. Similarly, we also had many partners that focused on schools as important institutions that can spread behaviour by influencing children. And WUSUP, I think I saw a colleague from WUSUP on the line, has been working in Ghana with the Ghana Education Service. So Mary, you will be familiar with this, to run a school hygiene campaign in 30 schools. And that was really raising awareness of what children could do and also impart that knowledge to the rest of their family. We worked with UNHCR, the UN Refugee Agency, to support refugees and host communities as well with COVID-19 prevention measures. And I think HBCC overall is a very effective public-private model of partnership that we were able to scale up in response to COVID-19 and try to reach universal hygiene coverage. And I think one thing I just want to leave you on as a last note, I think we've achieved a great deal with HBCC and we've managed to reach over 1 billion people, but the current levels of planning and investment that we have on WASH, we know we won't come close to reaching these goals, that those 17 ambitious goals that I mentioned at the start, the SDGs, SDG 3 particularly on health, SDG 6 on water and sanitation, we are a long way off on the current plans. So really, we're doing our part as a private sector company, we're doing our part through the HBCC, and we call on governments, on donors, on policymakers to really prioritise hygiene as a key health intervention. Make sure you adopt costed national roadmaps to ensure plans and finance go hand in hand. And really, that means increasing investments in hygiene, making sure that everyone, everywhere has access to good hygiene.
Well, thank you so much, Elena, for those remarks, and congratulations on the amazing work of Unilever with the UK government. I think that going to the mindset of supply and demand and going with that idea at first seems very interesting in this approach. So congratulations and thank you for your presentation. I will now launch the poll that we had intended at the beginning. So remember, please, you might be seeing that popping up now. In your country, which social need has been mostly affected by the COVID-19 pandemic? Please answer that on the chat. And in the meantime, I will go back to now Purmina to make you a question about, given the changes that we have seen in the second wave of the COVID-19 pandemic in several countries, how do you think that we can ensure that we are strengthening adequate social protection measures for food and nutrition, especially in the second wave? What have we learned from the first wave that we can apply for the second wave?
Yeah, thanks, David. I will, reveal my biases a little bit as a researcher here, but I think what was very remarkable for me, I mentioned the Hunger Watch survey, for example, is that data was so powerful in showing that the measures that were put in place had reached people, but that they were still inadequate. And to me, that really spoke to the power of data to inform the direction that we need to go in. So for example, one may make assumptions that people's household budgets have been affected in X way, or that food insecurity has likely increased, so much in these geographic areas, etc. But until we actually have the data available to tell us that these are the ways in which people have been affected, and these are the ways in which they're struggling, and this is what they're struggling around, I think it will become very difficult for us to actually deliver a social protection sort of package that fully addresses, or gets as close to addressing those needs as fully as possible. One of the key things that we have learned through the last year is that it is possible to get that data where you have high technology penetration. And for example, in much of South Asia, we have very high penetration of cell phones. And so a lot of people have learned a lot about collecting fairly good data on food security, on the reach of social safety net programs, on what has happened to health and nutrition, and even some sensitive areas, using these kinds of remote data collection tools. And I think we really need to deploy them to their fullest, because that's what's going to tell us, what the extent of disruption to food security and nutrition we are seeing, but also the extent to which the social safety net programs that have been put in place are able to mitigate that. Because without that, without data, you're really flying blind. So I want to keep my response short. Maybe there are some other questions there. Yeah.
Yeah, I totally agree, Bormina, that the power of data is very important, and especially disaggregated data, for example, and also data that also has a gender approach, gender lens. So yeah, very important response from your side. Mary, I have a question for you. And before I make a question, I will now share the results of the poll. And it seems like in the participants' countries list, economic instability has been the most social need affected by the pandemic, which of course is related to food insecurity, also nutrition, and the remaining of the options in this list. So yeah, thank you very much, everyone, for sharing those options. Mary, my question is, you mentioned before four components of the response in Ghana. My question was, which of these four was the most challenging to implement? Mary?
Okay, thank you very much. I think the most challenging of them to implement was the governance structures. That is because when you think about governance, it's about decision making. It's also about interest of various stakeholders. And in the space of WASH in healthcare facilities, we have funders, we have service providers, we have regulators, etc. All these stakeholders have their own interests. And so establishing governance structures for us has been the most difficult. But then it's also the one, once we attained most of it, it was also the one that brought us a lot of achievement in the other pillars. As we speak, we still have outstanding milestones to achieve in terms of governance. For instance, in our healthcare facilities, we are supposed to have WASH IPC improvement teams, or what we call WASH committees, but they do not exist at this point. We are also supposed to have WASH IPC focal persons in healthcare facilities at district level, at regional level, health center level, right to community level. But we do not exactly have all these structures available. And the truth is, these are the structures that will drive WASH in healthcare facilities at all the levels, and make sure that every level is self-sustaining with leadership support from the level just above it. So that is our target, to make sure that we have governance structures who are well trained, well equipped. They have the right WASH IPT tools to be able to do assessment, identify gaps, introduce interventions to bridge these gaps, and ensure that WASH is adequately integrated into quality of care. And so that is one of the gaps that moving forward, we will be focusing on. Thank you very much.
Thank you, Mary. I think governance is a very important aspect for sustained success. And that brings me to my question to Elena. Elena, in terms of public-private partnerships, and in this case, the HBCC, what do you think is the best, what are good practices in terms of sustained success in these kind of partnerships?
Thanks, David. I think the most important ingredient for a successful public-private partnership really is making sure that you are leveraging the strengths of each of the partners involved. And I think that's part of why HBCC worked so well. We all fitted together a bit like pieces in a jigsaw. We bring the hygiene behaviour change expertise and the hygiene products. Colleagues at FCDO brought also additional funding and expertise in how to deploy programs at scale. And then our partners on the ground brought, the ability to reach the last mile and the access to the local communities, to the local areas that we needed to deliver this program at scale. So I think the most important part of a public-private partnership is that understanding that each of you has different strengths and each of you brings something different to the table, but by working together, you create something that is greater than the sum of your parts.
Thank you very much, Helena. Yes, I think that if we want to go far, go along. If you want to go far, go together. So yes, that's a very important remark and recommendation. And now it's time to wrap up this meeting. Unfortunately, we didn't have enough time to keep going with questions. I know that there are a lot of things that we can discuss about WASH and nutrition and social protection services during the pandemic. But before we wrap up, I will now launch a second poll just to get to know what people think to move forward, because of course we want to know how to continue the discussion. And my question is, where should we increase the investments in these aspects that I have mentioned before to protect women, children, and adolescents' health? And until in the meantime, while you're voting on the poll, I will now just make a comment about the next session, which is the plenary. So please go back to the main plenary into the platform so you can see the report back from these breakout rooms and continue the agenda that we have prepared for you. I will now end the poll in the interest of time, a bit biased poll because of the short notice, but in this case, we have a tie between increased economic opportunities and also social protection and support systems. Thank you very much for having attended this session. I hope that you have enjoyed it. And thank you so much, Helena, Purmina, and Mary, for those wonderful presentations. I think we have learned a lot, and we are very much motivated and inspired to keep advocating for women, children, and adolescents' health in the COVID-19 recovery and response as well. Thank you very much, and I will see you in the plenary. Have a good day.
Thank you.
Thank you, everyone. Bye.